A 65-year-old woman with hormone receptor positive, HER2 negative metastatic breast cancer develops a solitary symptomatic brain metastasis while her systemic disease is progressing after treatment with endocrine therapy plus palbociclib, followed by capecitabine. Her KPS is 80 and the lesion is surgically accessible. She has no known PIK3CA mutation. Endocrine therapy alone is considered appropriate primary management for her symptomatic brain metastasis. Answer: false. While responses of brain metastases to hormonal therapies have been documented, endocrine therapy alone is generally not appropriate for primary management, and local therapies, like surgery or radiation, are necessary, especially for symptomatic lesions. Following surgical resection of the brain metastasis, continuing capecitabine is the standard approach, giving her stable KPS. Answer: false. The patient developed the brain metastasis while her systemic disease was progressing on capecitabine, indicating resistance. Therefore, continuing capecitabine would not be appropriate. A change in systemic therapy is needed due to both intracranial and extracranial progression. Abemaciclib has demonstrated significant intracranial objective response rates, greater than 20%, in Phase 2 trials for HR-positive, HER2-negative breast cancer brain metastases. Answer: false. In a Phase 2 study of heavily pretreated patients with HR-positive, HER2-negative breast cancer and active brain metastases, the intracranial objective response rate with abemaciclib was modest at 5.2%, although the clinical benefit rate was higher, 24%. Following surgical resection of the brain metastasis, continuing capecitabine is the standard approach. Is reasonable local treatment strategy for this patient's solitary brain metastasis? Answer: yes. For patients with a favorable prognosis, KPS 80, and a surgically accessible solitary lesion, aggressive local treatment, like surgery, often followed by radiation, is indicated. Given her disease subtype, HR-positive, HER2 negative, is her risk of developing brain metastases generally considered as high as that for patients with HER2 positive or triple negative subtypes? Answer: no. Hormone receptor positive, HER2 negative metastatic breast cancer is associated with a lower incidence of brain metastases, around 15%, compared to HER2 positive or triple negative subtypes, approximately 1/3 each. Would platinum-based chemotherapy be a potential systemic therapy option following local treatment of her brain metastases? Answer: yes. Platinum agents are among the chemotherapies described as having activity against CNS metastases from breast cancer and could be considered as a next-line systemic option after progression on prior therapies. A 50-year-old woman with HER2-positive metastatic breast cancer underwent stereotactic radiosurgery, SRS, for 2 brain metastases 1 year ago. She subsequently received tucatinib, capecitabine, and trastuzumab with good systemic control, but now presents with neurologic symptoms. MRI shows progression within the previously treated lesions and 2 new small brain metastases. Her extracranial disease remains stable. The observed CNS progression definitively indicates failure of the tucatinib-based regimen's intracranial activity. Answer: false. While CNS progression occurred, the tucatinib regimen demonstrated significant CNS activity in HER2 CLIMB, improving CNS PFS and OS even in patients with active brain metastases. Progression can still occur, and other factors like radiation necrosis versus true progression need consideration, although new lesions suggest true progression is likely contributing. Trastuzumab deruxtecan, T-DXd, is a preferred next-line systemic therapy option in this scenario. Answer: true. T-DXd has shown intracranial activity in patients with both treated and active brain metastases and demonstrated a significant PFS benefit over T-DM1 in patients with stable brain metastases post-trastuzumab taxane. Given progression on a tucatinib-based regimen, T-DXd is a highly appropriate next-line choice. Worsening CNS symptoms after SRS and subsequent systemic therapy like T-DM1 can sometimes be due to treatment complications like radiation necrosis rather than tumor progression. Answer: true. Case reports suggest agents like T-DM1 might increase brain edema following SRS, potentially mimicking progression. Pathology in one instance revealed radiation necrosis without viable tumor, highlighting that worsening symptoms may stem from treatment effects. While T-DM1 wasn't used here, the principle applies to complex post-treatment scenarios. Is continuing the tucatinib-based regimen appropriate given the CNS progression? Answer: no. The patient has progressive intracranial disease well on the tucatinib regimen. Even with stable extracranial disease, CNS progression necessitates a change in management, typically involving local therapy for the progressing CNS lesions and often a switch in systemic therapy effective in the CNS. Would lapatinib plus capecitabine be considered a reasonable systemic therapy option after failure of the tucatinib-based regimen? Answer: yes. Lapatinib plus capecitabine is an acceptable alternative or later-line option for HER2-positive metastatic breast cancer with brain metastases, although its activity after prior tucatinib is not well described. Is further local therapy, example, repeat SRS to new or progressive lesions, or WBRT, a necessary component of management for this patient? Answer: yes. The patient has symptomatic CNS progression with both new and progressing lesions despite prior SRS. Further local therapy is indicated to control the intracranial disease, along with adjusting systemic therapy.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.